This issue of surgery in synchronous oligometastatic disease, so you've got maybe primaries and metastases that you could operate on simultaneously. What is the big issue about this?
Well, it shows a little bit of the multidisciplinarity that we are talking about at this conference, because 20, 30 years ago it was rather rare that patients were referred for surgery of metastatic disease. And we have always said if it's only liver metastasis from colorectal cancer, there's a 30–40% chance of a long time 5-year survival. And referrals have really improved. What has happened now is that we got much more efficient systemic treatments like chemotherapy and biological drugs. And we can today shrink the tumors, especially in the liver, in 75–80% of cases. We know that now from our national population-based registers in Sweden. So the numbers you reach in clinical trials, we can actually reach them in the clinic.
Right, now liver metastases is one organ that you can look for mets and successfully operate on, but what about other sites?
Yeah, so lung has also become more common that you operate on. I would say it's more rare that you have a disease where you have only lung metastasis. It's more often that you have both lung and liver metastasis. But we don't exclude a patient anymore. So oligometastatic means that you have a few metastases. So if you have 2 metastases in the liver and if you would have 1 in the lung, we consider curative treatment as an option.
In fact, clinicians have talked about cure when they're referring to surgery for metastatic disease. Is that a reality?
Yeah, it is. And we are now getting the 5-year survival data from, again, the Swedish National Liver Register. So looking at 2,000 cases that have been liver resected, which means liver resected and maybe something else also, we know we cover all patients operated, having done surgery in Sweden. We have a 50% 5-year survival, not the 20–30. We have a 50% 5-year survival. And that is with the principle we have: use chemotherapy to downsize, to shrink the tumors, and then do curative treatment. And it works in half of the cases.
Right. Now, this is why you stress the multidisciplinary team. How exactly should the team be working?
The most important thing is that every patient who has oligometastatic disease, and even those who have it in a very advanced stage, should be referred to an MDT board, this multidisciplinary board, where you have the expertise from the surgeons. It could be a colorectal surgeon, a liver surgeon, from the medical oncologist, the radiologist, very often a pathologist, and the coordinating nurses. And then we also always want the doctor responsible for the treatment of the patient, so we can discuss, what is the view of the patient, the quality of life today, and their performance. So this is the group. And then the students, the residents, all those who have a fantastic learning experience by running an MDT.
So effectively, chemotherapy and radiotherapy could be neoadjuvant treatment, so to speak, and then the surgeon comes in to deliver the final blow to the tumor.
Today I would say you're almost right, because definitely that's the role of chemotherapy and biological drugs. But it's fascinating because radiotherapy is now coming in as a surgical tool. We've been treating single metastasis in the brain with what we call the surgical knife. And this is now also becoming a reality for lung metastasis and for liver metastasis. So the first option, in my view, is surgery. But sometimes it's instead an ablative technique, heat or heat with microwaves or radiofrequency or radiotherapy. So let's move radiotherapy into the curative part.
Right, so what then is the brief summary, the take-home message for cancer doctors coming out of all of this?
If a patient has oligometastatic disease, metastasis in the liver, lung, refer them to an MDT, a multidisciplinary decision board, so that we can decide whether we should go for multidisciplinary treatment or not.
Thank you very much.